Well, hello there again. Excuse me, but you got a little cake or icing or something in the corners of your mouth. Looks like you've been eating some cake. I guess it's a good thing we're going to talk about carbohydrate health concerns in this lesson, because it looks like you need to be aware of what excess carbohydrate can do, but also some of the current concerns that might come from carbohydrates not being properly metabolized and that kind of thing. So we are going to discuss in this lesson and look at some health concerns that specifically deal with carbohydrates. So for basically diabetes and hypoglycemia is what we're going to discuss. But anyway, this graphic here I've got just basically shows that anytime you go to any extreme, either elevated blood glucose or low blood glucose, that is going to be a health concern. So we'll discuss those and see what we can enlighten you on as far as the nutrition aspects of those diseases. But first thing I want to do, though, is just read you a little story I thought was kind of interesting, and it kind of puts everything into perspective, because anyway, just a story that looks at how we should look at life. So let me just read it to you, and I hope you find it interesting. So the difference between rich and poor people. One day a father of a very wealthy family took his son on a trip to the country with the express purpose of showing him how poor people live. They spent a couple days or nights on the farm of what would be considered a very poor family. On the return from the trip, the father asked his son, "How was the trip?" "It was great, Dad." "Did you see how poor people live?" the father asked. "Oh, yeah," said the son. "So tell me, what did you learn from the trip?" asked the father. The son answered, "I saw that we have one dog, and they have four. We have a pool that reaches to the middle of our garden, and they have a creek that has no end. We have imported lanterns in our garden, and they have the stars at night. The patio reaches to the front yard, and they have the whole horizon. We have a small piece of land to live on, and they have fields that go beyond our sight. We have servants who serve us, but they serve others. We buy our food, but they grow theirs. We have walls around our property to protect us. They have friends to protect them." The boy's father was speechless. Then his son added, "Thanks, Dad, for showing me how poor we are." Isn't perspective a wonderful thing? Makes you wonder what would happen if we all gave thanks for everything we have, instead of worrying about what we don't have. Appreciate every single thing you have, things you see, friends and family, and yourself. Life is too short. Enjoy the moment. I just thought that was a good story, so I hope you enjoy it. Anyway, we're going to start out looking at diabetes. And basically, diabetes is a group of diseases that affect your blood sugar levels. And so it has to do with looking at defective mechanisms that would keep your blood sugar high, and so that would be called hyperglycemia. So what we're going to do is just go through and look at the different aspects of diabetes, look at the hormones that are involved, and look at what some of the conditions that would occur to being diagnosed as being diabetic, and then in the end look at what we can do nutritional as far as nutrition aspects of related to diabetes. So I just wanted to show you some graphics about how diabetes is a growing disease in this country. You can see from 1994 to 2008 that the obesity has increased, but also diabetes has increased. So we'll be looking at type 2 diabetes, which basically is based on obesity. But diabetes is a growing concern in this country, but a lot of it, type 2, comes from a growing concern of obesity. So we'll be talking about obesity later under energy concerns. Looking at Oregon specifically, because that's where we live, we can see that diabetes is going up to 2008. Now you might ask why we don't have more recent data, and basically they update data about every 5 to 10 years. And so it may be a few more years before we get above 2008, since we're just in 2013. But anyway, the basic idea is look at the trend. The trend has been going up since 1994, and it's not increasing. Look at newly diagnosed diabetics. It's really, again, the trend is to go up. We had a big upswing in 2008 and to 2010. So, and I think it's still, I know it's still rising. So diabetes is still a concern. And then the correlation between obesity and diabetes is just shown on this graphic. So there is a correlation there. And excuse me, this thing's going crazy. Looking at Oregon obesity, I just thought it was interesting to look at Hood River County, where I live close to, versus Multnomah County, and there the obesity rate, it's kind of odd that it is a lot different. You'd think people who live out in the farming areas would not be quite as obese as in Multnomah County, but that's what the statistics say. But we look at diabetes, and you can see that Hood River is lower, but not too much, than Multnomah County, and it is rising. So these are just some guesstimates of upwards of 6 to 7%. And then there is an ethnic basis for diabetes. The ethnicity does play a role, but again, you can see the trends in all ethnicities are rising. So it doesn't really matter the ethnicity, it just matters that the trend is going up and up and up. And it doesn't show the Spanish population, but there is a high incidence of diabetes within the Hispanic population, or Mexican American, or whatever population. It is also very high. I just thought this was interesting. 50 fat diabetic, but ahead of you. But the guy's doing the right thing. Part of the thing about obesity is exercise, so he's doing the right thing. So let's look. Pardon me, this thing's just got a mind of its own. So let's just look at the regulation of blood glucose. Normal levels are between 70 and 100 milligrams per deciliter. It used to be, not too long ago, it used to be, if you're below 125, you're fine. But now they're diagnosing individuals as pre-diabetic, and trying to catch it before it actually gets into the diabetes stage. So the rule of thumb now is normal would be considered 70 to 100 milligrams per deciliter. But what this is basically showing, the renal threshold is basically the threshold where you're not dumping sugar. And so you wouldn't have glycosuria quite yet. But everybody's level is a little different. This is just kind of an average level here. So some people can be up here, some can be lower. So again, it's just based on your kidneys and how much they can hold back sugar and not dump it into your urine. But again, what we're seeing, the normal trend would be, let's just say you started between 80 and 100 there. The normal trend is after you eat food, then your blood sugar level would go up, but then insulin's going to kick in and so forth and bring it back down. And then a normal level would be to get down here and just kind of go straight along. Okay, what the extremes are is if you eat, especially carbohydrates, and your blood sugar level goes up, but it just continues to go up above the renal threshold and basically stays there, that would then classify as you being hyperglycemic. Okay, but you can be hyperglycemic without being diabetic. So there's some other symptoms. So hyperglycemia is one symptom. There are two other basic symptoms that would be required for you to be considered diabetic. But on the other extreme, if it goes up, goes down, then completely goes down, way down, below 50 and 40 in that range, you'd be considered hypoglycemic, which is another health concern dealing with blood sugar levels. So this is kind of the scale that we're looking at. So let's first of all just look at some of the hormones that are involved in controlling blood sugar. The first one, obvious, and you've probably heard a lot about it, is insulin. So insulin is made by the beta cells of the pancreas. Its main job is to be produced when blood sugar levels are high. Actually, insulin is produced before your blood sugar levels gets high, because as you remember from the regulation, we have the vagus nerve that basically is going to tell all your body parts when things are being eaten and to prepare to receive food. So insulin is actually going to be prepared and made before the sugar actually gets to the blood. But it's going to be made in response to a potential glucose absorption and increasing blood sugar levels. It also has a feedback where it's going to prevent the glycogen in the liver from being broken down into glucose and then put into the bloodstream. So basically, the feedback system was, hey, we're going to get some glucose coming in, so there's no reason for you to put any into the blood. So we're going to stop breaking down your glycogen, and you can just keep it. It also is going to have an effect of increasing the stores of glycogen in the liver. If the liver isn't full, there is a limit to how much glycogen that liver can hold. If you go over that limit and go over the limit that goes into the muscles, then it's going to go into adipose tissue and become fat. And then also it prevents fat breakdown, which basically is one of the premises of the Atkins diet. The Atkins diet, as you know, is low carbohydrate. So the basis of that would be, if you're eating low carbohydrate, you're not going to produce insulin, therefore you're not going to prevent fat breakdown, therefore your body would use more fat as an energy source. The problem with that is it's going to go into ketones, and you get into ketosis, and long term that's not a good thing to be in, ketosis for a long term. Very effective. Atkins diet is losing weight fast, but it's not a long-term solution. It's not one that you'd want to live on for the rest of your life. So anyway, so this is kind of the effects of insulin. Insulin comes from the pancreas, and the pancreas is right behind the stomach here. So the pancreas is pretty important. It's an exocrine gland as well as an endocrine gland, because we talked about the pancreas when we were talking about digestion and making lipases and proteases and those kinds of things. So they're an exocrine, so they go through a duct that would go into the duodenum. But it's also an endocrine gland that's going to secrete insulin and other hormones right directly into the bloodstream. So it's a pretty important organ. But for our case, we're talking about its relationship to insulin. The main part is the islets of Langerhans, and you can see here are the beta cells as part of that process. We will be talking about alpha cells also here in a minute, but the beta cells are going to produce the insulin that are going to be secreted out into the bloodstream. Now, a lot of students think that insulin is going to grab onto sugar and bring it into the cells. Actually, insulin is a hormone, and hormones tell cells what to do. In this case, insulin is going to fit into the insulin receptor, and it's going to send a bunch of signals to produce glucose transporters. And so these are going to be, if you've had 112, hopefully, these are going to be active transporters that are going to basically transport the glucose from the bloodstream into the cell. And they do have names, and I'll show you some later, like GLUT4, GLUT1, GLUT2, those kinds of things, depending on what cell they're part of. But the GLUT part basically is an indicator that it's going to transport glucose, okay, in this case. The the next thing that's going to happen is that, back up. Okay, I got frustrated because it went on, but this is just another illustration of where insulin's going to work, where it fits into the insulin receptor and basically then goes throughout the process of producing an active transporter that's going to take glucose, bring it in, and eventually this is going to be put together to make glycogen. So this would be in the liver or in the muscles. So these wouldn't necessarily be part of adipose tissue, but they'll be part of either the liver or the muscles. So here's just an example for you. I don't expect you to remember these and where they are distributed. I just wanted you to know that they do have names depending on what tissue they are part of. GLUT4 they were just looking at as part of skeletal tissue. In cardiac and that kind of. GLUT3 is in your nervous system and other places. GLUT2 is going to also be in the liver and that kind of thing. So just depends on where it is, but all of them are going to be glucose transport proteins. Okay. I keep hesitating because I want to see what's going to go on. Anyway, so that's basically insulin. Amylin is co-secreted with insulin, so it comes from beta cells also, and it has three things that I'd like to remember about amylin. It is going to suppress glucagon secretion, and glucagon, as we're going to see in the next, as part of the next hormone, basically is going to tell the liver to produce, to break off sugars from the glycogen and send them out to the blood. So if you suppress that hormone, it's not going to be able to tell the liver to do that. So basically then you keep the glycogen in the liver and not increase liver secretion of glucose. It's also going to basically make you feel less hungry so you don't eat. That's one of the feedback mechanisms amylin is, that is going to make you feel fuller, and that's what satiety means. Satiety means a feeling of fullness. So this is one of the feedback mechanisms that is basically going to tell you, hey, you're getting enough to eat, we're getting plenty here, so you can slow down and stop eating. Doesn't mean we are, as we'll see later in one of the other lessons, but it just means that in reality we feel full, but if we see dessert, we're going to still eat it probably. So here's the amylin that is going to be secreted again from the cells of the pancreas. It's going to go to the liver and basically do the things that we just talked about. So it's co-secreted with insulin. I'm going to keep my hands on both of these. Here I was just talking about glucagon. It's produced by the alpha cells. Earlier I showed you that the beta and alpha cells are in the islets of Langerhans, but the alpha cells are going to produce the glucagon, and it's in response to low blood sugar. So insulin and amylin would be involved when your blood sugar levels are high. Glucagon is going to be involved when your blood sugar levels are low. So you would see production of insulin and amylin after you've eaten something. You would see production of glucagon whenever your blood sugar gets low, for example, when you're sleeping at night, or when you are tending to get more hypoglycemic if you haven't eaten for a while and your blood sugar levels go down, then those blood sugar levels are going to be brought back up to homeostasis by the production of glucagon, which will tell the liver to break off sugar from glycogen and put it out into the blood. So therefore that's why it's stimulating the liver glucose to release glucose, and helps to basically maintain homeostasis of your blood sugar levels during a fasting period, which would be like when you're sleeping at night. And so here's just an example. Here's glucagon, and then it's going to go about the process of taking glycogen, making glucose, and then that glucose is going to be secreted out in the bloodstream because of low glucose levels in the bloodstream. Okay. GLP-1 is kind of a newer one. It's an interesting one. It is secreted not from the pancreas, but from the cells of the intestinal tract. And so it's going to be basically stimulated when you have food in your intestinal tract. So not necessarily in the bloodstream. So when things get into the intestinal tract, the duodenum and so forth, then the GLP-1 is going to be produced. It's going to then do a feedback, positive feedback, to cause insulin to be secreted. Then it's going to also help amylin suppress glucagon. It's going to help with amylin to make you feel satiety. It is the stimulation of this is actually going to increase the amount of beta cells and increases beta mass. It actually helps keep the quantity of beta cells within the pancreas, so that stimulation. So what they found is if GLP-1 is not working, it's not being secreted because of some defect, then the beta cell mass actually starts going down and down because it's not being stimulated. It'd be similar to your muscles shrinking because you're not working out, you're not working your muscles, or your bones get thinner when they're in a cast after you've broken the bone and you don't walk on it for a while. Your bone mass gets smaller because of not being used. Well, basically the GLP-1 will stimulate the beta cells and keep them active and keep them dividing and so forth, and also helps their efficiency. So that's good. So GLP-1 here is coming from the intestines, goes to the pancreas, and then stimulates things, the beta cells and so forth, in the pancreas. Okay. Epinephrine is one that is produced during fight or flight mechanisms. So when you're under stress, your fight or flight, then adrenaline is meant to utilize more glucose, so you can make more ATP, so you can have more energy to either run or fight or whatever you're going to do. The problem is, and we'll talk a little bit more about this when we get into hypoglycemia, I mean, the initial response is to increase blood sugar, but also the response is going to be to produce more ATP, and your nervous system is going just crazy like this. Where it can come into play with hypoglycemia is because if you're under constant stress or fear, or if you're afraid, or you're stressed because you're afraid of something or nervous, or you're just fearful all the time, you can't sleep, you can't do things, and maybe, who knows, you've got a restraining order out on somebody or something, and you're just nervous all the time, or you've got a nutrition test coming up and you're just stressed about your nutrition test, but this would be stress that goes on 24/7. The fight or flight stress is supposed to be for a very short period of time, just enough energy to get you going. But if you're under fear 24/7, you're going to be producing a ton of epinephrine. Your nervous system is going to be going 24/7. You can bring your blood glucose levels too low because you're just under that stress and you're just producing ATP, and you're under anxiety and you're just going nuts. That can happen. So we'll bring that up again. But again, why we're talking about it here is because it is a hormone that can affect your blood glucose levels. Okay. And so here's epinephrine. That would be the same as glucagon, but it's going to cause glycogen to produce glucose and then fuel that for fight or flight. Okay, so we'll talk more about epinephrine, adrenaline later. So let's look at the clinical manifestations. Basically, these would be what would diagnose you as being a diabetic, or in this case, a pre-diabetic. So pre-diabetes would be if you, fasting glucose would be if you fasted for like 12 to 14 hours and then had a blood test. So it would be around in the 100 to 125 range. or if you had glucose tolerance, and I'll show you a picture in a minute, where you would have a glucose tolerance test where they give you this really sicky, sugary stuff, and then they would take blood samples and monitor if your glucose goes up, and then if it comes back down. If it goes up and stays up into the 140 to 199 milligram per deciliter range, then you would be considered to be pre-diabetic. And so they've just recently been using that as a diagnosis because they will look at this and look at trends, because you start out and you're maybe at 105 and they say, well, you're getting into the pre-diabetic range, and then the next time you go back to doctor it's 115 and then 120. So they're noticing a trend, and in some cases they may prescribe insulin even though you're a pre-diabetic or some kind of a therapy because they don't want it to get to the 125 range. They don't want it to get to the 200 range. They want to catch it before it gets there, before it can start causing some of the physical problems that we'll talk about just in a minute. So prediabetes is now a diagnosis. It would be something that you'd find in a patient's chart. And it would be, again, looking at, okay, we're in the pre-diabetic, we need to start looking and doing something so it doesn't continue to trend upwards. Now, true diabetic, you'd be over a 125 fasting and 200 blood glucose. But also one thing they're also looking at, you may or may not have heard of, the A1C test. I mean, the official name is glycosylated hemoglobin A1C. But usually if you're working in a hospital, they'll just say, what is their A1C levels? Because everybody knows what that means. And we're looking at, and I'll show you a little diagram that shows what does 7% glycosylated hemoglobin represent. But let's just talk a little bit about that for a second after we get through this. So here's the glucose tolerance test, where they would give somebody a sicky thing, and then they would, or glucose, and they would basically just monitor blood glucose levels. If you're normal, it would go up, obviously, and then come back down and kind of level out. If you're diabetic, it's going to go way up here, and that's where you would be classified as hyperglycemic. Okay, so hyperglycemia is one indicator of diabetes. You can be hyperglycemic but not have the symptoms of diabetes. Still, you just have high blood sugar, but it is waves a red flag. So there are two other things that are going to be manifestations that would clinically diagnose you as being a diabetic. So we'll talk about those in a minute. But let's look at the A1C and what it means. Basically, if you haven't had an anatomy, or if you have, you should know that red blood cells live about 120 days. After about 120 days, they're going to be broken down, and everything's going to be kind of reused for that. So the A1C level is a diagnosis that will tell you what is happening over a 121-day period or a 3-month period. Okay, so it can tell you how things have been going on average for the last 3 months, as opposed to a finger stick, which basically tells you at the moment, or a series of finger sticks that may not be as accurate. This tells you an average. Because what happens is that over time, depending on your blood glucose level, I mean, your glucose will bind to red blood cells, but the higher the level of glucose, the more glucose is going to bind per hemoglobin. And so if you have low blood glucose, not as much sugar will bind to the red blood cell. If you have high glucose, more will bind, and so they call that glycohemoglobin, but the test is the A1C. So basically this is the idea. A low A1C, you just have a few sugars attached to the hemoglobin or the red blood cell. Here you have more, so this would be high A1C levels because you have a lot of sugar that is attached to the red blood cells. And so this would be an indicator of how your sugar levels have been over a 3-month period. It used to be a good test to see if patients were actually telling you the truth, because they would come in with finger stick. And hopefully you know what a finger stick's, where you poke your finger and you have that little thing they advertise on TV that takes your blood sugar level. And so usually, you know, for new diabetics, they'll have you do it a couple times a day, or even once before eating, once after eating, kind of a thing. And so a lot of times patients would not tell the truth because they didn't want to be in trouble, and they didn't want to, you know, they wanted the doctor to think they're doing a good job. But then they would have low blood stick, you know, finger stick levels, and then they would look at their A1C and it was really high, so they knew something was goofy there. And so the glycosylated hemoglobin, the A1C, is a more trustworthy test than the finger sticks basically are. So here's the A1C scores, and you can see, you know, 7 is good, you know, within this range if you're a diabetic. You know, if you're not diabetic, you know, obviously you want to be below that. You know, obviously you'd want to be in the 5 range if you could, between 5 and 6, because that basically indicates that you are in, you know, below the 100 range. But for a diabetic who's really struggling to control, they feel that a 7 is a pretty good number if they can maintain that over a 3-month period, because your blood sugar is going to go up and down and up and down and up and down, you know, every day. But if you can average 7, you know, about 150, you know, for a diabetic, they're figuring that that's a pretty good number that they can be comfortable with if they can stay with that, because it's not extremely, it's not of the real high levels that you can get to. Anyway, and you know, hyperglycemia, you know, it looks like, well, 380, I mean, that's really high. It is not uncommon for an undiagnosed diabetic to come into the emergency room with a diagnosis of blood sugars of 500, 700, something like that, because they didn't know they were diabetic and they were eating just tons of food and tons of carbohydrates and stuff. And then all of a sudden they just feel goofy and they feel a little weird. And so they go to the emergency room, get tested, and there you are, you know, 500, 700, kind of a thing. Okay, the second thing that would be a clinical manifestation that they would look at to give you a full diagnosis of diabetes would be ketoacidosis, diabetic ketoacidosis. Basically, when your cells aren't getting glucose, they have to get energy from somewhere. And so that energy tends to come from abnormal or inefficient breakdown of fatty acids. And those fatty acids would then become ketones. Well, ketones are basically acidic, and so you're going to be acidifying your blood and go into what can become ketosis. So if they can also do a test where they can test your ketone levels, and basically they can tell, you know, that would be another diagnosis that you're, you know, you have hyperglycemia, but are your cells not getting sugar? Okay, because you can be hyperglycemic again. Your cells can be getting sugar, so they're not burning fat. But another indicator that you're not utilizing the glucose and it's high in your blood would be to see if your body's having to make ketones in order to get the cells energy. And so if your ketone levels are high, then you would know, yes, you are having to make ketones. So basically ketones come from, you know, hopefully if you've taken 112 and you've looked at in the respiration, we talked about acetyl-CoA. And so, and if you remember, fatty acids can only be broken down if they go into the mitochondria, into acetyl-CoA. If you remember, they're broken down into 2 carbon units that go into the mitochondria, become acetyl-CoA. Then they can go through the Krebs cycle and electron transport chain and become energy. But in this case, then what you're going to be making is, you know, you're going to make a lot of acetyl-CoA, but some of it, you know, is going to become ketones or acetones and those kind of things, which then can be, you know, build up in your bloodstream and cause ketoacidosis. So here's another, you know, inefficient or absent insulin. Basically, you're going to be creating these, ketogenesis, where you're going to, neo means no, basically none, so you don't have any genesis of glucose. So you're making ketones, you increase the ketones in the blood, and basically, what this is saying is that, if you look at this whole scheme where it says increase ketones and glucose, basically what's going to happen is the cells are going to be signaling the liver, saying basically, hey, we must be in hypoglycemia because we aren't getting any glucose. There's no glucose. And so I think you should release more glucose because we're in hypoglycemia, even though your blood's actually in hyperglycemia. So the liver can break off sugars and put them into the blood, when you're diabetic, increasing your blood sugar levels even more. So you can even become more hyperglycemic. Because your body's response is, hey, we don't have enough sugar in the blood because our cells are not getting any, so please put some more in there so there will be some more available. But it's not going to be used. So you can become even more hyperglycemic, but the cells will saying, well, we're not getting any glucose, so let's try something else. Let's work on getting some ketones here. And so you're going to break down fat and you're going to increase the amount of ketones. So you can become more hyperglycemic and, more ketone, bodies basically in your bloodstream that way. And then the third one would be if you have glycosuria, which basically means you've gone over the renal threshold and you're dumping sugar into your urine. Okay. What that can cause is obviously polyuria, and I can't remember if I may have a little shot after this. I can't remember what slide comes next. But anyway, we talked a little bit about this in BI 112, or if you took another biology class when you're talking about osmosis and diffusion. We basically said if you have high glucose in your blood, basically that makes your blood hyperglycemic. Therefore, you are going to have more water in your cells and the interstitial fluids than you do in the blood, which is basically going to cause water to move into your bloodstream. Therefore, the high water is going to cause you to have polyuria, so increase urination. Then you're also going to be very thirsty because you're urinating a lot, you're taking away fluids, and your body's response is, hey, let's drink some more because we're losing a lot of fluids. And then you're going to be very hungry because your cells aren't getting glucose, and so they're sending signals, hey, feed us, feed us, feed us, we need more carbohydrates. And so not only they're telling the kidney to send signals, but this, to send glucose to the blood, but they're telling your body, hey, feel hungry because we need to get this guy to eat something because we're low in glucose here. And then because you're not getting any glucose, you are burning fats, and so you do get weight loss, but also a lot of the energy, the glucose that would be going into the cells and also maintaining your weight was going to go down the drain. So a lot of signals there. So hyperglycemia, diabetic ketoacidosis, so ketone level, and glycosuria would be the three main tests that they would do that would give you a full diagnosis of being a diabetic. Okay. What are the complications of diabetes? Number one, here are the risks. You can see the risks go very high. Cardiovascular disease, there's an increase, 400 times increase in cardiovascular disease with diabetics. And then, strokes because of high blood pressure that's going to be caused and things like that. So a lot of emphasis to get your blood sugar into control, whatever means it takes. This is just looking at renal disease. Some of you are going to be working in renal units where they do a lot of dialysis. A high percentage of those patients will have had diabetes. because it is going to basically destroy nephrons and parts of the glomerulus. And so I have this little blurb that I got that talks about podocytes. I've never really heard about podocytes before I found this, but these are basically part of the glomerulus, which is a filtering mechanism within the kidney, and basically they don't have receptors, so they're going to be impaired, and so they result in abnormalities. And then also that lack of insulin is going to affect the cytoskeleton for whatever reason and the structure of that, so it's going to basically damage the kidneys through that, and so that's where you get nephropathy. But here, as I found a picture of podocytes, and so basically, if you don't know the glomerulus, the blood comes in and goes through these series of capillaries that have holes in them, and the back pressure, because this tube is smaller than this one, so the blood can't leave as fast as it comes in, will cause pressuring things to be filtered out into this, used to be called Bowman's capsule, now they call it the glomerular capsule. But here, just the filtrate would be water and urea and different things, but also sugar, and then it goes down these tubules that become part of the nephron. Well, here are the podocytes, and apparently it causes this structure to become defective, so you can't filter things, and so it basically ruins the ability to make urine. And so it results in nephropathy, which means you can't filter your blood without going to a dialysis unit or something like that. And so macular degeneration, because you increase hypertonicity of your blood vessels going through your eye, basically, and it can cause hemorrhaging, it can cause aneurysms, you get high blood pressure in those areas, and so it can cause some retinopathy to occur as being diabetic. So that's a problem there too. The other thing about what it can cause is getting numbness because of lack of if you think about it, if you have high sugar in your blood, it becomes very syrupy. I should have brought out my little sticks, but I don't think you could see them on the screen. But basically, your blood becomes more like syrup, and so it flows a lot slower, which is why you may have heard that diabetics have to really watch their feet to make sure they don't injure their feet. So if they have any kind of injury on their feet, it's very difficult to heal that sore, because number one, it takes more time for your immune system and stuff, white blood cells and stuff, to get to the wound because your blood is syrupy. But also the bacteria love your sweet blood. They're going to grow very rapidly with all the sugar in your blood and that kind of thing. Diabetics really have to monitor their feet and make sure that there's no sores down there. If there are, they need to go to a podiatrist or to a doctor and get them, analyzed and make sure that they're taken care of properly. But the other thing about it is they can get numbing in the feet, numbing in the fingers, as part of the nervous system being affected by the bloodstream. And so it sometimes can, if you have numbing of the feet, it can be difficult to feel if you step on something sharp or something. And so you could get a sore down there without even knowing it, which is, again, why they recommend diabetics, especially, when you take your socks off, then you inspect your feet and make sure that there's no problems down there. Okay, corns can be a real issue with diabetics, having them taken off, so you really need a professional to do that. You wouldn't buy an off-the-counter thing to take off corns. You would want to go to a podiatrist or a doctor and get them really taken care of properly. Okay, so needless to say, diabetes has a lot of side effects. Let's go over the classifications. Type 1 is basically the lowest level diabetics. There's only maybe the range they give is 5 to 10% of all diabetics are type 1. It seems kind of a wide range, but it's within that range. It's an immune system problem. It's not really a diet problem, and that's what I need you to understand, is that in most cases type 1 is not caused by something nutritional. It's an immune system problem. It's a very brittle. It's called brittle because, and it's fast acting, rapid, because it can happen overnight. One day you feel like you're normal, the next day you're not normal. It just almost happens overnight. Very rapid. It's very brittle because it's very hard to control. When you first start trying to control it, then it gets very hard to get it nailed down to how much insulin do you need, that kind of thing, versus your insulin and food intake are kind of balanced, so it's kind of hard to balance that. It can go up and down and up and down. One day in the doctor it's fine, next day it's really high, come in the doctor it's really low, and so they're always monitoring, which is very frustrating when you're diabetic, especially because type 1 usually occurs in early life. If you're a teenager or something, it's very difficult because your life is just put into a little whirlwind. Your sugar's up and going down and up and down, and I mean your hormones are raging, and you're in that decade where just a lot of things are happening in your life, and then this happens and the thing's going up and down, and you want to get in control, and it doesn't get in control, and you're just it's an emotional drain, very stressful, which is why a lot of times type 1 teenagers are ones that don't follow a diet. I mean, they just don't want to. They're upset, they're mad, they're angry that they've got this diabetes, and they can't do what their friends do. They can't just go out for pizza. They have to watch it. They have to take shots, and they don't want their friends to know, and so they go into the bathroom in secret and take a shot, and just stuff. It's just all kinds of stuff. So it can be very brittle, very hard to control, which becomes very, very frustrating. It's an autoimmune, which basically means that your body is attacking itself. And it's going to destroy beta cells, therefore reducing beta cell mass and reducing the amount of insulin to the level where you don't produce any insulin at all. But again, no nutritional cause. It's not caused by eating too much sugar. It's not caused by eating too much carbohydrate. It's not caused by obesity. It's caused because of your immune system. Something's going on. Okay? Well, what causes your immune system to attack itself? Well, what they find is that there are some people who are just genetically prone. Their genetics is such that they are more prone to the immune system attacking the beta cells. But what they found is it takes a stressor to do that. And a stressor can be, you don't even have the symptoms of type 1. Then you have a fever or, a real sickness where your fever gets real high. And then all of a sudden, in a short period of time after that, you find out you have diabetes or a heavy stress or hormone changes or something. Other people, what they found is that viruses will attack the beta cells. And, again, these individuals are genetically prone for some reason to receive these viruses, and they're able to get into the beta cells. Well, the body's response is, hey, I need to get rid of that virus. The only way I can do it is to destroy the cell. And so your body attacks itself. And so they can test for type 1 by testing for antibodies that are being produced. And these are some of the ones that they could check to see if, yes, it is indeed type 1 because you're producing these antibodies that are autoimmune antibodies to your system. Okay? So that's the issue there. And again, what it's going to do is if you lack insulin, you are not going to be producing the transporters. Therefore, you cannot get the the sugar out of your blood. So the obvious thing that you would have to do is take insulin injections in order to have that insulin to make the transporters. Okay, and so this is just another figure that says basically the same thing. If you have diminished insulin, you don't have the signals to make, in this case, the GLUT4 transporters. You do still have some glucose transporters, but it's very diminished, and you just can't get all the blood out, so you continue to be hyperglycemic. All right. Type 2 is a different story. It has to do mainly with insulin resistance. It's used to be called adult onset, but we're finding more and more individuals in the adolescent age that are getting type 2. We're seeing more and more, and we are seeing a high increase of individuals in the age range of about 35 that are getting type 2. It used to be it was in maybe your late 40s or in your 50s where you would see type 2. And a lot of it had to do possibly with the fact that, you know, you've been overusing your pancreas, something happens to the pancreas or something. Or, you know, your cells just get tired and get resistant, something. But this indicator is really, and as we'll see, because of obesity. It is a progressive loss of beta cells. Type 2 can eventually become type 1 if it is not taken care of, because there will be over time a loss of beta cells. So you start decreasing. Initially, type 2 is not a problem with production of insulin. You produce plenty of insulin, which sometimes it's called non-insulin dependent diabetes, where you don't really need insulin because you're producing plenty of insulin. The problem is it's not being able to the cells aren't responding to it, so they make the transporters. So the same condition is going to come about is you're not making transporters. It's just in the case of type 1, you're not making the insulin. In type 2, the cells don't respond to the insulin. So something's happening with the receptors, or, you know, maybe not necessarily it has to be the receptors. It could be the receptors aren't sending a signal, or they may be sending a signal, but it's not being responded to, and we would call that post-receptor defects after the receptor. So we'll talk about those. I wanted to bring up gestational diabetes because what they found is that there is a higher risk of women getting type 2 diabetes if they have had gestational diabetes during pregnancy. And so gestational diabetes is diabetes that only manifests itself during pregnancy. And so there are some theories on why. They have found some decrease in GLP-1, so it's not stimulating the production of insulin during pregnancy because of hormones that do that. And then there's some indication that amylin could decrease or maybe be resistant, that is just not working properly. So that could lead to the diabetes, because a lot of cases, once pregnancy is over and delivery is over, then the diabetes goes away. But what they found is it should wave a red flag to those individuals who have had gestational diabetes that I am at risk, a higher risk than the normal population. Or I shouldn't say normal, but the other individuals who haven't had gestational diabetes, to getting type 2. Because there are individuals who are obese who don't have type 2. But these individuals would be at higher risk that if they became obese, that they would get type 2. So it's just a red flag that's being raised. So what does obesity do? The main obesity that is the problem, and we'll bring this up later and later in heart disease and cancer and everything else, is visceral or central. This would be obesity that is where you have fat underneath the rectus abdominis, the muscles here. So it will be underneath that layer that is going to push the muscles out. So these would be individuals that have a very hard stomach, but it sticks out. It's not the jelly, jiggly Santa Claus fat. It's the fat that is very hard and sticks out because it's pushing against the muscle layer. This is the worst fat that you can have. I may have mentioned it before, but I'm just going to emphasize it again, that this is the worst fat you can have. Mainly it's called visceral. It's not really, I mean, sometimes some people may use abdominal obesity, but you can have subcutaneous obesity, which is the jiggly stuff on the outside of the muscle. That would be in the abdomen. So it's more better, if you will, to be called visceral obesity, because it's around your intestines and your viscera. But what visceral obesity can do is it can result in insulin resistance, which basically means that you're going to have faulty insulin receptors. So the receptors are going to be made incorrectly. And then so the insulin doesn't fit. Remember from biology we said that these receptors are protein, and if they're not made correctly, then the insulin, things won't fit in there. Post-receptor defects is what I was talking about, meaning that maybe the receptors are fine. They receive the insulin fits the receptor, starts the signal process, but in the process of relaying the signal to the nucleus and so forth, something gets screwed up. So that would be after the receptor, post-receptor, and this would be part of the relay proteins. Some of you that had my biology class, remember we talked about relay proteins when we talked about cancer. And we talked about the RAS protein would signal the tyrosine kinase, and we'd have these 35 proteins on the way to the nucleus. These relay proteins could be part of the defective process. But in any sense, the signal is not getting to the nucleus, so the nucleus can send the information, go through transcription, translation to make the transporters, and through the ribosome and the rough ER and all that stuff that you should have learned, and embed them into the plasma membrane to take the sugar out. So it's just not happening. If you have been obese for a long time, you are basically running your pancreas at 100 miles an hour, max. There can be a point where your pancreas says, enough is enough, I give. And it starts, your beta cells start dying off. And so you decrease your beta cell mass. So in this instance, it's called pancreatic exhaustion. It has to do with obesity, but it doesn't deal with how obese you are. It deals with how long you have been obese. So it's a length thing versus, how big of how much obesity you have. So it's the length, and so over time you're just overtaxing the kidney, your pancreas. Your pancreas gets exhausted and says, I give. Okay, and just waves their white flag, throws in the towel and says, I'm done, kind of a thing. There is another theory basically that and it's hard to explain. Let me explain it with my hands, but kind of visualize that you have this cell and you have these receptors, and kind of visualize, because it's a little bit, receptors are a little bit more complicated than we make it, but let's just visualize that it takes two receptors to receive the insulin. And so the distance of these receptors apart is significant because the insulin has to fit into both of those receptors. So as you get obese, your adipose cell size, the cells get bigger. So the theory would be that the two receptors, as it's kind of like blowing up a Mickey Mouse balloon, right? So the face is all crunched up and it kind of widens out and the ears get farther apart. Well, these receptors are going to get further apart as the cell gets bigger. They're going to be squeezed further and further apart. Well, if the insulin's only this big, it can only fit one part of it into one receptor. The other receptor is way over here. And so the insulin isn't effective because it don't fit. doesn't fit, okay? But a lot of times you can, if you lose weight, you will not be type 2, you will not be diabetic. You can control it with weight. So the theory would be that as you lose weight and your cell size gets smaller, the two receptors become closer together again, and so the insulin will fit. Kind of a theory. It's called the fat cell theory or adipose cell size theory. You know, it may have some merit, but who knows. But anyway, these are some of the things that would be caused because of visceral obesity and that kind of thing. But we're going to talk more when we get to heart disease, but in this instance, visceral obesity, and you probably heard that fat cells send out signals. They are not just storage vesicles. They actually send out signals that are going to cause things like inflammation, or they can cause, you know, havoc with some of your cells. And especially because they're visceral, they go directly into the blood and go directly to the liver, and then directly to your cells, and they can cause more havoc. So let me just go through a scenario to try to help you understand why obesity would cause type 2 diabetes. And this is just an illustration, basically, that here the insulin, you have plenty of insulin. The insulin fits in receptors, but there's a defect in the signaling somewhere. So the information doesn't get to the nucleus, the transporters don't get made, basically, and so you don't get any glucose in. And so they just don't work. So that would be a post-receptor type of defect, or they would call it insulin resistance. So that'd be one type. So here's the picture with the obesity. It says the developing picture is that so FFAs are free fatty acids, which basically means, you know, from a triglyceride, you have the free fatty acids, and are going to enhance secretion in obesity and insulin resistance syndromes, okay? And so it could contribute to beta cell failure and development of type 2 diabetes. And this is going to be especially important with visceral obesity, releasing these free fatty acids into the bloodstream, okay? So here's kind of the idea is that when you start breaking down fat, visceral fat, it seems to be the one, some of you may know if you've tried weight loss, is that the subcutaneous is the hardest to lose. The visceral is the fat that's going to be used first. So even though your stomach will go down because of lack of visceral, you may look like fat because your subcutaneous takes longer because the visceral is going to be used first. Well, if the visceral is used first, then it's going to produce, you know, the lipids that are going to become the free fatty acids. The key is, again, oxidation. We talked about oxidation earlier. So these free fatty acids can become oxidized. They can decrease glucose utilization, increase gluconeogenesis, and then you're going to get hyperglycemia. So the cells will not take up glucose. The liver will produce more glucose, so neo means new, so new glucose genesis or production, and you're going to become hyperglycemic that way. The other mechanism, again, looking at insulin resistance, you're going to increase lipolysis, increase plasma in the blood, free fatty acids. This is tumor necrosis factor that can cause inflammation, which is another problem. And then, but, you know, the ultimate result is that you're going to become hyperglycemic by reduced plasma insulin, decrease glucose, or increase glucose output because the liver, the cells are going to say, hey, we're hypoglycemic, and then decrease in glucose transporters. So all of that's going to be happening because of the breakdown of visceral fat. It seems to always go to the next frame when you have these circles that I've done. But anyway, here's another scenario, is that here's stresses from obesity, and stresses can be because of the tumor necrosis factor that causes inflammation, because of excess free fatty acids that are coming from the breakdown of visceral fat. And so these would be called stressors, okay, because they're going to stress the cells. They're going to get in. They're basically going to stress. Here's the endoplasmic reticulum, basically the rough, and it's going to cause unfolding of the proteins. Remember the folding of the tertiary and secondary structure of the proteins. And so then basically the long term, it's going to inactivate this, and you're not going to make the glucose or the GLUT transporters. Okay, so the visceral obesity, the more you have, the more you're going to use it, is going to cause stresses and is going to result in lack of transporters, which therefore we would call insulin resistance. Okay? So, anyway, there is a type 1.5. It's called by many different names, but you can be diagnosed 1.5. You have kind of a combination of type 1 and type 2. They can see some antibodies in your system. There may not be as much as in type 1, but they can see some antibodies there that are starting to attack your beta cells, and but they may not see a decrease of insulin for 5 to 10 years. So sometimes they diagnose as type 2, but if they would take an antibody test, they would see that you are producing antibodies. So not quite type 1 because you're still producing insulin, and not quite type 2 because you're producing antibodies. So it's in between. It's a type 1.5. So there can be a diagnosis of that. So there's some complications. Hypoglycemia, sometimes referred to as insulin shock, because of an increase of insulin. So it could be normal insulin production, but you just didn't eat right. I mean, you didn't eat breakfast because were in a hurry. You had an emergency call or something happened, and you took your insulin. Well, the insulin's going to work no matter if you ate food or not. It just works, takes down carbohydrates, and continues to work until it's done its thing. And so it can reduce your blood sugar levels and become hypoglycemic, or the reason it's called insulin shock is because it's the insulin that's bringing down. The other instance could be that you take double injections. Now, those of us that don't have diabetes, you'd wonder, well, how in the heck could someone take 2 shots? Well, it's like anything else. If you've done it for many, many years and it becomes a habit, then sometimes you forget if you did it. I'm sure some of you have gone through life and you've done things so many times that every once in a while you wonder, did I turn the stove off? I can't remember if I turned the stove off. Kind of a thing. Well, insulin diabetic may get up in the morning, they're kind of groggy, and they say, oh, I better take my insulin before I eat. So they take their insulin, and then, they take their shower and they do the thing. It's going, well, geez, I can't remember. I better take my insulin. So they take another one. It's just, again, you'd wonder why, but it happens. So they get double insulin, and it takes double sugar out. So that can happen. Hyperglycemia, ketoacidosis, again, production of ketones, oftentimes happens with individuals who have not been diagnosed yet. And so they don't know they have diabetes. So they're just munching out like crazy. And so they have an increased food intake, especially carbohydrates, and their blood sugar gets way up to 500, 600, 700, and they just don't know. And so they go into a coma. They can go into a coma. Both of these, you can go into a coma. Or you can basically forget to take your insulin. And you can eat your food and you're in a hurry and you're eating your food and say, well, after I eat, I'll take my insulin. All of a sudden you get an emergency call. Or you think maybe like up there, you say, well, I already took it. I know I did my insulin, so I know I did. I don't want to take doubles, so I'm going to just go like I did. And so like at 10 o'clock in the morning, they start getting the symptoms of hyperglycemia. And so we'll talk about some of the symptoms in a bit, but you can get shaky and you can stuff. But obviously, what you would have is some of the symptoms we talked about earlier would be increased urination, thirsty, hungry, those kinds of things, would be a sign that, hey, you need to maybe go see the doctor. You may be hyperglycemic, kind of a thing. Doesn't happen too much in diabetics. Both these conditions, most diabetics that have been diabetic for a while can feel the symptoms coming on before it gets too bad. But if you're misdiagnosed or undiagnosed, then you wouldn't know, kind of a thing. So what is our goals as far as nutritional therapy? So here would be some numbers. Some of these won't make any sense yet, but they will make sense after we get done with cardiovascular disease. We've talked about this. Preprandial basically means before you eat. Postprandial means after you eat, and usually it's the blood test is taken about 2 hours after you eat, and this is basically taken just before you eat, or after you wake up in the morning or something like that. So that's what these words mean. We're going to talk about these when we get into the lipoproteins. I believe it's maybe even the next lesson. Well, I think we do energy and then that. But anyway, before heart disease, we'll talk about these. But LDLs are considered the bad guys. HDLs are the good guys. Triglycerides, you know what they are. So these would be important because if you remember, diabetics are 400% higher risk of heart disease. And so these are going to be important for risk for heart disease. Blood pressure would be important because of high blood pressure in your retinas and basically everywhere. And then sloughing off of proteins that could signal a kidney problem. So and then a BMI of less than 25. We'll talk about BMIs. I think we'll talk about those later. But anyway, so these are numbers we're shooting for. And these are numbers that you'll try to strive. That doesn't mean you're ever going to meet those, but these are goals that if a person comes into your hospital, they're under your care, these would be goals that you would tend to want to achieve. Okay. When you get into working in hospitals, hospitals are accredited, and so they I think it's either 3 or 5 years, there will be a team of professionals that will come in and look at patients' charts and look at things about the hospital and reaccredit the hospital. Well, they will be looking in patients' charts, and so they will know these numbers, but they really don't expect that for every single patient you will reach their number. That's not their goal. The goal is going to be that with the healthcare team, you are going to do whatever it takes to try to achieve those numbers, which means that everything needs to be documented in the patient's chart, that you have done everything possible to achieve these numbers. You have monitored their blood pressure, and you have counseled them about blood pressure. You've maybe put them on medication. You have talked to the patient. That's where the dietitian comes in. They would talk to the patient about their hemoglobin, about their glucose levels, about their lipid levels, and all of those. They would talk to them and explain to them why it's important to get it down. The doc would possibly, prescribe Lipitor or something like that to try to get them down. So what the accreditation team is looking for is, have you tried to do it? They're not really, to be honest, expecting you to meet those goals because everybody's different. You can't expect everybody to meet those goals. You can't expect perfection, but the expectation would be that you have tried to do everything, and the only thing that's going to be used as criteria, as if you've tried or not, is what's documented in the patient's chart. Basically, the premise is if it's not written down, it didn't happen. So they can't, if they go on the patient's chart, they see no documentation that the dietitians talk to the patient about lipid levels or anything, then they're going to say, well, they're going to take points off, basically, and that it will do no good if the dietitian says, oh, yeah, I remembered I talked to them on Tuesday about this, and we discussed this, and you can talk to the patient about it, and they'll tell you we talked about it. Holds no bearing. If it's not written down, it did not happen, period. So these are the goals that we're trying to achieve. Hypoglycemia, let's talk a little bit about that, because the nutrition care plan for hypoglycemia and hyperglycemia are basically the same. They're both dealing with blood sugar levels, and they're both dealing with a problem with maintaining those glucose levels. So they're both going to be dealing with how do we monitor glucose levels. So let's talk about hypoglycemia, and at the end we'll talk about the nutrition care plan that would be for both of these. So hypoglycemia is low blood glucose, so down to 40 or 50. Remember, the normal is between 70 and 100. So below 40 to 50, then you would be diagnosed as being hypoglycemic. So we talked about epinephrine and the stress. So if you're under 24/7 stress, that can cause your blood glucose to go down. Or worse would be if it's a pancreatic tumor that's affecting the ability, or sometimes it can cause the increased production of insulin. And so you'd have overstimulation of insulin, which would cause you to hypoglycemic. So hypoglycemia is not a disease. It's a manifestation of a disease. Because if you remember, diabetes is a disease because of hyperglycemia, because of ketoacidosis, because of glycosuria. Hypoglycemia is a diagnosis. It's a manifestation of something else that's occurring. So it's a secondary issue. So hypoglycemia is something you should not diagnose, self-diagnose. It needs to be diagnosed by a physician where they do the same exact things, glucose tolerance test, fasting glucose, the same things that you do with diabetes. And so if you do have hypoglycemia, they need to address other issues. And it's not simply a matter of, oh, let's just give them more sugar. We'll give them injections of sugar to deal with their hypoglycemia, because that's not the problem. Okay? So please, if you have friends that say, oh, I'm hypoglycemic, and they have not been diagnosed by a physician, you should encourage them to go get diagnosed, because it could be something worse than they think it is. Okay, I'll get off my soapbox now. But anyway, so there's two types. Reactive is kind of the one that maybe is more normal, and so it would be more common, I guess. But basically, after you've eaten a lot of sugar, if you will, so go to a party, cake and icing like I saw in your mouth earlier, or drink punch or whatever, and a lot of carbohydrates and that, simple carbohydrates and things like that. About 2 to 4 hours after you eat it, you get the symptoms of hypoglycemia, and I'll go over the symptoms in a minute. It could be because of an overproduction of insulin. Insulin, sometimes if you hit the system with a ton of sugar, the response of the pancreas to producing it could be overproduction, because it just kind of misdiagnoses how much sugar is going to be there, or it expects more sugar, kind of a thing. So the feedback is, oh, they're eating pure sugar, kind of a deal. And so we need to repair, because if they keep eating this, we're going to need more and more insulin, but you don't. So you kind of stop. But so the overproduction of insulin can give you those symptoms of that. It could be something else, but sometimes it could be an overproduction of insulin. Fasting is more long-term. It's going to be up anywhere from 8 to 24 hours after you eat, and you haven't eaten for a while. Okay? So it would be something that maybe you'd manifest when you wake up in the morning after a night's sleep or something. But it could be an overproduction of insulin, but more of concern, it could be a pancreatic tumor. So this would be the worst one, kind of a thing. So again, just don't self-diagnose. Here are some of the symptoms. Again, shaking, sweat, dizziness, hunger. So these would be the main ones. The top ones would be the main ones that would be for reactive. So you just feel kind of goofy. You're kind of sweating, and your palms of your hands are kind of sweating. You feel the anxiety would be not that you kind of feel nervous, but it's kind of that, like before an exam where you have those butterflies in your stomach, kind of a nervousness. So it's not a nervousness or anxiety because of fear. It's an anxiety of, you just a little bit nervous, again, like before an exam. It's not like you're fearing getting hurt or something like that. And then, you feel a little hungry, but it's not a painful hungry. It's more of a sicky butterfly-y hunger, kind of a thing. Now, fasting is more the top and the bottom. Visually impaired, weakness, fatigue, headache, irritable, those kinds of things. But just because you know somebody that's irritable, don't diagnose them as being hypoglycemic, okay? But anyway, so these are more severe type of things. So if you know anybody that goes through this and they say, oh yeah, I've been hypoglycemic, so every time I get the symptoms, I just pop a lifesaver, or I have some, glucose pills and dextrose pills or whatever, and I just pop them and I feel better, kind of a thing. Not a good thing, okay? They need to go to the doctor, all right? So what is the nutritional care plan for both, hypo and hyperglycemia or diabetes? Carbohydrates should be still about 40 to 50% of your diet. You should have or are going to do a meal plan using carbohydrate counting. I put this in there because I want you to know it's not that you would probably ever do carbohydrate counting as a nurse, or if you're going to be dental hygienist or something like that. But a dietitian would probably do that. But I think it's important for you to understand what they're doing, because once again, you are going to be the person that the patient is going to talk to most. The dietitian would probably do the carbohydrate counting and all this stuff like that, but the patient is going to ask you why they are putting you on this plan that is going to be carbohydrate counting. So I think it's important that you need to know how it's done just one time. And so when you hear the word, you'll kind of have an understanding. And I think the only way to understand is to actually do one. So that's why we're doing it. It's not to be mean. It's just hopefully to help you down the road. But basically, it's based on carbs. It's not based on how much fat you eat, how much protein you eat, that kind of thing. It's because the carbohydrates are going to turn into the sugars. So it's based on how many grams of carbohydrates that you eat. And it's based on portions of 15 grams of carbohydrate servings, if you will. And they're really called carbohydrate choice. So you have 15-gram choices that you can make. And so the dietitian will go over carbohydrate counting with the patient, basically, and usually the spouse, if there is one, or significant other, especially if they do the cooking, kind of a thing, and explain carbohydrate counting and explain what it means. And basically, it'll take some time for patients to understand it. But basically, it's just choosing foods that basically give you a certain amount of carbohydrate choices, again, 15-gram choices per day, spread out evenly throughout the day so that you don't have a big push of sugar all at once. So when you do your carb counting plan, what you need to understand is you may come up with 20 choices of carbohydrates that you have to split up throughout the whole day. you need to make sure that you're eating basically 6 meals per day, and you need to spread those 20 carbohydrates over evenly as you can throughout the 6 meals per day. So basically you would have a breakfast, a 10 o'clock snack, a lunch, a 2 o'clock snack, a 6 o'clock dinner, and maybe an 8 o'clock or 9 o'clock snack. Okay, you cannot miss one of those 6. There's basically 6 to 8 servings per day. You can't really skip one because and add to another one, because you're going to have a big push of sugar all at once if you eat a lot at one time. Plus your insulin levels, especially your type 1 insulin levels and sugar intake are going to be monitored. So if you have like a slow release insulin, you need to basically even out your sugars throughout the day, because if you don't, then the slow release is going to maybe release when you don't have very much sugar in your blood. You could become hypoglycemic just for that instant. So it needs to be spread out through the whole day, not skipping any of the meals, and just even out your sugar all day. So I think you'll understand better when you actually do the plan. It's going to be difficult for you to understand, but I think that puts you in empathy with a diabetic patient who has not been to college, who doesn't understand, is not very good at math and stuff, how they feel. So I think it's going to put you in empathy with somebody who has to do this. And so I hope you can appreciate why I'm having you do it, even though it will be difficult. So don't think that you're going to get it straight up. You may have to ask questions, but we will try to help you through it. And I think once you're through with it, I think it'll help you understand it, but also understand what a diabetic has to go through. And I think that's important, especially if you're not a diabetic. Glycemic index, we have a little discussion about that. And so you probably, I can't remember if you've done it yet or not, but anyway, if you have, you understand the glycemic index. Basically, it's the premise of they took white bread and they fed it to several people in this study. And then after a 2-hour period, they checked their blood sugar levels. And they said, okay, white bread will raise blood sugar levels on an average this much over in a 2-hour period. And then that was kind of their baseline. And then they basically fixed a scale of all other foods based on white bread being, sometimes they use the scale as white bread being 100, and that's the point scale for the glycemic index, or 70. It just depends on which scale you use. But then anything over that number, whether it's 70 or 100, anything over that would be food that would raise the blood sugar level faster and higher in 2 hours. Anything below that would be slower and lower in 2 hours. So the goal would be to choose low glycemic index foods that kind of either are low in carbs or low in sugars, or that the sugar trickles in very slowly. And so you might be surprised, because glucose, fructose has a lower glycemic index than glucose, because fructose takes longer to be absorbed. I mean, same amount of calories and everything, but for a diabetic, it can work better because, well, it's twice as sweet, so you use, half as much, but also it trickles in, so it has a lower glycemic index. Glycemic load basically is, if you look at the glycemic index of some foods, they look high. But if you look at the glycemic load, which basically means how much carbohydrate is actually there, even though the carbohydrate that's in the food would raise your blood glucose very high, very fast, there's not very much there. So the glycemic load would be very low, and I'll show you an example of that. So here's the idea, is that we have white bread and white rice are going to be pretty much the same, but basically here, the white bread, the glycemic index was 70, so that's your goal. That's they're saying 59 to 60 is medium. Anyway, so I said there's different levels, but anyway, your goal would be obviously in here in the medium range, so right around 70 or so. So you can see that white rice, which would be similar to white bread, would be about in that range, kind of a thing. But watermelon has a high glycemic index. If we look around in baguette, I don't even know what that is, bread of some kind, I guess, would have higher. But you can see bananas, even though they're a fruit and seem sweet, they would not really, because there's a lot of fructose in there, kind of a thing. So you can see the glycemic index, and then you would say, ooh, based on the glycemic index, I shouldn't eat very much watermelon. Okay, well, but if you look at the glycemic load, there's not a ton of sugar in watermelon. So therefore its glycemic load, or basically the overall effect, is not going to be very high. So you can see low is 10 and it's a 3.6. So even though it has a high glycemic index, there's not very much carbohydrate there, and so it's not going to be that big of a deal. Whereas you look up here, this has a high glycemic index, but also a high glycemic load. So that would be kind of double trouble, kind of a deal here. So anyway, but white rice, not a bad glycemic index, but towards the higher end maybe of a glycemic load. So that's the difference between those. So, this is not something that you would send a patient home with. This would be something that after the dietitian gets through, doing a diet study on the patient, basically doing a recall or a diary or something on the patient, finding out what they like to eat, because again, the premise is going to be, the patient may eat some stuff he shouldn't, but what's the point? If you take away those foods they enjoy, then are they going to really stay with it? I mean, the compliance rate in reality for persons on diabetes following a diet is maybe about less than 20% actually comply. So if you give them something that they're not going to like, it ain't going to work. It'd be lower than 20%. Anyway, so you work with the patient, you allow them to have some foods they enjoy, but try to limit them, especially if they're high glycemic index, high glycemic load foods. You would basically say, okay, these are going to raise your blood sugar really fast and a lot. So what we need to do is, I'm not going to completely take them away from you, but we need to really cut down on your portions of how much you eat per week or per day. And so if they like to eat something high, every day, then you would possibly say, well, could we try maybe you could try just eating it 4 times a week, the same amounts you normally eat, but 4 times a week instead of 7. Could we try that kind of a thing? You think that would work? Kind of a deal. If they say no, then you would say, well, would it be possible that we could try maybe half of a serving per day for 7 days a week instead of your whole serving? Instead of eating a whole cup, would you be willing maybe to try half a cup a day, kind of a thing? Any way you can get it, but the idea would be to try to decrease those glycemic index, glycemic load foods as much as you can, because they're going to be the problem. So anyway, so you wouldn't send home the patient and with a big book, because there's a big book on this, and say, well, you need to look up every food and see what their glycemic index is and glycemic load, and we need to have you document this, and then you're going to follow this completely. It's not going to work. So you just kind of use this as a tool to help them to make better choices. Oops. Let me do something here. For some reason, it's not going. So I want to continue recording, but we're missing some stuff. So let me go here. And how am I going to do this? Slideshow. There we go. Set slideshow. I need to go up 2 more. Pink, pink. 64. Okay. So now we can go. So we're going to go here, go here. Sorry about that. So now you know how I set my PowerPoints. But anyway. So we talked about the glycemic index and that kind of thing. So the next point would be how much protein. Well, 15 to 20%, that's higher than what we talked about. We talked about 12%. And so, but we're dealing with the immune system here. We need to make sure we get plenty of protein that can be dealt with the immune system, because we're going to be a little bit compromised there. We need to keep up their immune system and that kind of thing. But it needs to be lean foods, things that don't add a lot of fat and that kind of thing. Lipids, 30% of your diet or less if you can. And then, you know, again, these are all going to be related to heart disease. So we need to make sure we monitor those and how much that we get of those. But pretty normal that way. Multiple feedings, as I mentioned, 6 to 8 feedings per day. Trying to even out, especially with the carbohydrates, trying to even out the amount of sugar that goes into the blood system one time, because you have a compromised blood management system, if you will, and so you need to just trickle things in, even it out throughout the day, and then kind of balance that. Reasonable weight, again, below BMI of 25 if you can, but sometimes difficult. But if you can do it, then great, because that will mean the patient doesn't have to go on insulin, doesn't get pancreatic exhaustion, that kind of thing. Alcohol, limit to 1 drink per day. And 1 drink is considered 12 ounces of beer, 5 ounces of wine, 1.5 ounces of liquor. Okay. If you can. I mean, again, the alcohol is going to mess with your cells. All right. And so the more, if you can get the person not to drink alcohol, the better. But is that realistic? Probably not, especially if they go out to dinner and they enjoy wine. But try to encourage them to limit it to 1 drink a day if they can. Okay. But that will be up to them. You know, you can only make a patient do what they want to do. If they don't want to, they're not going to. But you can encourage them to do that. So that's carbohydrate. I know it's kind of a long, drawn-out lesson, but you're going to encounter a lot of diabetics. I wanted you to know as much as you possibly can about diabetes, and hopefully this will kind of stick with you. And when you get to be a healthcare professional, if somebody has diabetes, you can either go back to this stuff, or you can at least you can remember some of it and encourage them, but also and be able to answer their questions. All right. So we'll